Dr. Mohammed Subhi wants to ask the first question. Go ahead, Dr. Mohammed.
لا أنا بس عايز أعمل initiation للdiscussions.
Sure.
Regarding NVAF, we are using NVAF since a long time now. I need your practice. How to evaluate bleeding of the NVAF, what you're going to do when going to non-cardiac surgery. In practice, Antonio,
Yeah.
You are giving NVAF to your patients. If there is a bleeding, are you going to do PT, PTT, or just depending on to stop the drug? How can you evaluate the NVAF? I know that warfarin, we have already INR, but what about the NVAF? And if you're going to non-cardiac surgery, are you going to stop for 24 hours or 2 days before? How can you make it?
But if the patient has NOAC is given for atrial fibrillation with non-valvular disease, in my opinion, if you stop for 2 or 3 days, the risk is not particularly high of stroke. So I think you can stop for 2 or 3 days.
Okay. Good morning, ladies and gentlemen. Sorry about that. First of all, allow me to thank Bayer Middle East for their kind invitation. It's indeed my great pleasure and honor to be here in this exclusive interventional cardiologist. It is nice to see friends and colleagues after 2 years of hiding behind screens. I was given the task to talk about comprehensive protection for non-valvular AF. And before I start, I would like to share with you my disclosures. And I would like to point out that I've been contracted by Bayer Middle East to date to give the session, but I have no financial interest in Bayer. Let me start with this hypothetical case. This is Mrs. Emil. She is 75 years of age. She was diagnosed 7 years ago with diabetes and hypertension, and she came to you complaining from fatigue and palpitations, and you diagnosed her with non-valvular AF, and she has moderate renal impairment with a creatinine clearance around 46 ml per minute. So there is nothing fancy about this case. It's a routine case that we see in a clinical practice. This lady, she is elderly. She has a few risk factors, including diabetes, hypertension, and renal failure. So the fundamental question is, what does protection mean for our patient? The comprehensive answer to this question would be, we need to prevent stroke, prevent cardiovascular death, prevent vascular events, preserve renal function, mitigate bleeding risk, and optimize the dose. Protection, as you know, is at the center of care for patients with AF, and it has been really emphasized in the latest European Society of Cardiology guidelines in the management of atrial fibrillation. And they encourage the use of the ABC acronym, and ABC stands for, the A stands for anticoagulation and avoiding stroke by utilizing CHA2DS2-VASc and Hazard score. B stands for better symptom control, while optimizing the rate and consider rhythm control, including antiarrhythmics, cardioversion, and ablation, while C stands for identification of comorbidities and cardiovascular risk and address them and advise patients on proper lifestyle management, including obesity reduction, regular exercise, etc. Let us talk about, diabetes and AF. So diabetes is a growing epidemic. In 2019, approximately 463 million adults were living with diabetes. And by 2045, this number will rise to 700 million. So let us talk about our region. In one of the studies, as you know, diabetes is quite prevalent in our region. And in this particular study, it has been shown that Saudi Arabia and Oman, they have the highest diabetic rate at 31% for Saudi Arabia and 29% in Oman, while the rate of diabetes in Kuwait, Bahrain, and UAE were roughly similar at 25%, and Qatar 16%. AF, kidney disease, and diabetes are all independent risk factor for stroke. We know that AF is associated with five-fold increase in the risk of a stroke, while diabetes has twofold increase in the risk of a stroke. And finally, chronic kidney disease has 30 to 60% increase in the risk of a stroke. Diabetes is one of the leading causes of chronic kidney disease, which in itself increases the risk of a stroke and bleeding in patients with AF. And based on the third National Health and Nutrition Examination Survey that included more than 15,000 patients aged 20 years or more, this survey concluded that those who had the combination of diabetes and kidney disease, they have the highest CV mortality and total mortality compared to individuals with each risk factor alone. Diabetes is well represented in landmark trials. Just to remind you that 23 to 40% of NOACs randomized clinical trials included patients with diabetes, while 22 to 29% of the Garfield AF and Orbit registries has patients with AF, and 30% in the electronic health record administrative claim database, they have diabetes. So diabetes is well represented in these landmark trials. And needless to say that diabetes has a few microvascular complications, including retinopathy, nephropathy, and neuropathy. Furthermore, diabetes has macrovascular complications like stroke and cardiovascular disease. 8 out of 10 individuals with diabetes die from CV events, and in population with AF, 7 in 10 patients die from CV causes. Now, if we look at subgroup analysis from the famous Rocket AF, so in this subgroup, we extracted a pool of patients with diabetes, and we found that the rate of a stroke and systemic embolism was the same between patients taking rivaroxaban and warfarin, while vascular death in this group of patients from the Rocket AF was significantly lower in patients taking rivaroxaban. Now, if you look at other trials and see what happens to CV death, we look at, for example, Aristotle and Rely, and compare them to Rocket AF. Obviously, I'm putting this slide, and my intention is not to do direct comparison because we cannot really compare apple to oranges, but we can actually have some sort of a glimpse on the performance of these three agents when it comes to CV death. Rivaroxaban has significant 20% relative risk reduction of CV death in patients with AF and diabetes, while in apixaban and dabigatran, that was not statistically significant, and there was no benefit when it comes to CV death. If we look at the efficacy and safety of Xarelto versus warfarin in case of major adverse cardiac events, or MACE, and major adverse limb event, or MALE, in patients with AF and type 2 diabetes based on market scan database. And obviously the primary endpoint, as I mentioned, is MACE and MALE. And you can clearly conclude from this slide that rivaroxaban associated with significantly reduced MACE and MALE. And we are talking about here the hazard ratio of 0.75 for MACE and 0.37 in MALE. Despite the efficacy, the major bleeding was not really different between the two groups, and this is really reassuring. Now, if you look at other agents like apixaban and the efficacy of this drug in stroke and systemic embolism and CV death based on or stratified based on diabetic status, we will see that apixaban associated with similar rates of stroke and systemic embolism and CV death, regardless in patients with or without diabetes. Similar conclusion can be made on edoxaban, where there is no difference in stroke and systemic embolism or CV death in diabetics or non-diabetics. The Reloaded study, which I will talk about it shortly, it's a very interesting study that looked at patients with AF and diabetes and specifically address progression of kidney disease. And as you can see that both rivaroxaban and apixaban has significant reduction in the progression of renal impairment to end stage or dialysis. However, for the risk of acute kidney injury, only rivaroxaban showed reduction of 28%, while major and non-major clinically relevant bleeding was the same in diabetic and non-diabetic population. Another retrospective claim database analysis of patients with non-valvular AF and coronary artery disease with or without peripheral arterial disease receiving rivaroxaban. And you can see from this slide that rivaroxaban associated with 32% relative risk reduction of major thrombotic vascular events with similar rates of major bleeding. Now, the fundamental question is there a chance to preserve ML kidney instead of having to replace them? Now, keep in mind that this patient has diabetes and she has already moderate renal impairment. This lady at high risk of progression of her kidney function. Now, the question is, can we slow this progression? And the answer came from this market scan database involving a cohort of more than 21,000 patients, patients taking either rivaroxaban or warfarin, and you can clearly see that the rate of progression or the rate of the development of acute kidney injury and progression to stage 5 kidney disease or dialysis requirement was significantly lower in patients taking rivaroxaban. Here, the hazard ratio between the two groups was almost the same, and there is a relative risk reduction of 28%. Based on IPM market scan database involving more than 77,000 patients with AF and atherosclerotic disease, keep in mind that half of these patients, they have diabetes, and this study in particular looked at 4-year incidence of MACE, MI, stroke, and CV death, and the study concluded that the use of NOACs associated with reduction in MACE, MI, stroke, and CV death compared to those taking warfarin. A study by Yao, and this is actually a very interesting study. He took actually 4 oral anticoagulants, apixaban, dabigatran, rivaroxaban, and warfarin, and he looked at 4 renal parameters, namely 30% or more decline in eGFR, doubling of creatinine, acute kidney injury, and kidney failure. And if you look at every agent individually, you can see that rivaroxaban score 3 out of 4 favorable outcome of renal impairment, while dabigatran scores 2 out of the 4 renal parameters in terms of benefit in renal function, while apixaban has no benefit in patients in renal function based on Yao analysis. Now, we know in patients with AF and CKD, renal function decline faster in those with VKA exposure versus non-VKA exposure. And the longer the patient takes warfarin, the higher chances of arterial calcification. And this is really a concept that we acquire in the last decade or so. And it seems that this unfavorable use of warfarin when it comes to arterial calcification in the kidney related to a GPM factor which exists in or the matrix glycoprotein factor which exists in N-carboxylated format, and the presence of vitamin K will actually help in the decarboxylation and the prevention of arterial calcification and glomerular hemorrhage. Coming back to the Reloaded, it's a German study from the insurance claims databases, and they looked at the risk of renal function worsening between NOACs and procamone, which is a type of vitamin K antagonist. And you can clearly see that Xarelto and apixaban significantly reduce the risk of end-stage renal disease versus phenoprocamone, while Xarelto was associated with a trend toward a lower risk of acute kidney injury versus phenoprocamone. Now, if you look at diabetics, Xarelto and apixaban significantly reduce the risk of end-stage renal disease, while only Xarelto was associated with significantly lower risk of acute kidney injury versus phenoprocamone, and this is basically confirming other studies which I presented earlier. Now, again, part of the protection of our patient, she is elderly. We see how we can use and how safe to use rivaroxaban in elderly patients. Again, subgroup analysis from the ROCKET-AF, where patients, they were actually 75 years of age and older. And as you can see in this group of patients, there is no different in a stroke and systemic embolism between warfarin or Xarelto with similar rates of major bleeding. The Sapphire AC study is a very interesting study which was carried out in 33 geriatric centers in France. And half of them, they were using warfarin, and the remaining half, they were using rivaroxaban. And the mean age in this group was 86, and these patients were sick. Now, this study showed that despite the fact that the CHA2DS2-VASc was high, the high group of patients, major bleeding and intracerebral hemorrhage was significantly lower in rivaroxaban compared to warfarin. Again, pooled analysis from the PREFER NAF and PREFER NAF prolongation registry, including 3,800 plus patients of 75 years of age and more, where rivaroxaban in this study showed a significant reduction in the net composite endpoint, which is defined as major bleeding and ischemic cardiovascular events, while similar rates of net composite endpoint between dabigatran and apixaban versus warfarin. It is important to choose the proper dose because patients with AF who were inappropriately underdosed result in higher rates of stroke and even higher rates of bleeding. So we are not really protecting our patients if we underdose them. And from the Garfield AF registry, it has been shown that inappropriate dose can result in high mortality. My last slide before the conclusion, I would like to share with you this study, which is observational open label study. This is a FIRE study which was carried out in Japan. It included 200 or 2,200 patients. These patients, they have a stable coronary artery disease. Patients, they have PCI or CABG or angiographically proven coronary artery disease, but they did not require any intervention. But this is all 1 year, before randomization. And the primary efficacy endpoint was MI, stroke, systemic embolism, and unstable angina, and all-cause death. And these patients, they were randomized to either rivaroxaban monotherapy or the combination of rivaroxaban and antiplatelet agent. And this study have shown that rivaroxaban monotherapy in patients with a chronic stable coronary artery disease associated with significant reduction in the primary efficacy endpoint. We're talking about 38% or 28% relative risk reduction, while there is a significant reduction in major bleeding in patients taking rivaroxaban monotherapy compared to rivaroxaban plus antiplatelet agents. So in conclusion, and my apologies, I don't know why this slide did not project very well. So in conclusion, Mr. Chairman, ladies and gentlemen, and my apologies for taking a minute extra on my time. Approximately 1 in every 3 patients with AF has comorbid diabetes. Diabetes increases the patient risk of stroke, CV death, renal function decline, and major adverse limb events. In patients with AF and comorbid diabetes, it is possible to avoid both irreversible macro and microvascular complications. Evidence suggests that patients with AF and diabetes receiving NOACs have not only reduced risk of stroke and systemic embolism, but fewer need for limb revascularization. And I guess I am forced to stop here because my slide disappeared. I think I've reached the end of my conclusion. Thank you very much for listening. Thank you, Mr. Chairman.
Thank you, Dr. Adel, for the nice presentation. If I will ask you one question, then we'll allow the audience to ask. If patient develops acute MI and then he develops around 2 hours of atrial fibrillation reverted spontaneously. Now, would you anticoagulate knowing that he will go to PCI with dual antiplatelet, and when you analyze his CHA2DS2-VASc would be more than 2? So would you consider this, although he had post-ischemic atrial fibrillation and then reverted spontaneously within 2 hours?
Yeah. I think the key question, Dr. Musa, is the 2 hours. And this is a matter of debate, and we can actually talk about it in details. But let us agree on something. AF in the setting of MI associated with high morbidity and mortality. And these patients, definitely they need anticoagulation. Now, the question is the duration. So if you are telling me 5 minutes, I will say no. But 2 hours, to my interpretation, this is long enough to justify starting NOACs on top of antiplatelet agents. And we have a very nice algorithm, and you are more expert than me in that regard, where we can combine NOACs with 2 antiplatelets therapy post-PCI, and there is a different algorithm for that. But yes, I would give anticoagulation.
Sure.
Thank you very much,
Please,
Dr.
go
Adel,
ahead,
for
please.
this elegant talk. My question is, patient with stage 4 renal disease and patient on whom hemodialysis stage 5, what will be the best, which is which, the NWAC or warfarin, and what will be the modification of those? This is a very common cases faced in the medical fields in our case.
So do you think this is an easy question? It is not an easy question. It's a difficult question to answer. And this is a matter of debate. But let me start by saying that we don't have RCTs yet to answer this question confidently. However, we have some data from observational studies and retrospective data to support the use of at least rivaroxaban and apixaban in patients with renal impairment. I would probably stay away from dabigatran because it's highly renally excreted. But I will share with you something very interesting. They estimated the level of rivaroxaban 15 milligrams, like the area under the curve. And they found that the concentration of rivaroxaban 15%, or 15 milligram in patients with CKD is the same as the concentration found in Rocket AF. Now, whether this translates into a meaningful benefit for a stroke or safety benefit for hemorrhage, it is not really known. So that's why we need to have an RCT to answer this question. Now, we do have some pharmacokinetics data and pharmacodynamics data from apixaban and rivaroxaban, which basically allow us to use these drugs in this group of patients. So, in summary, would I use NOACs in renal impairment? I personally use it. I don't have RCTs, but I am backed up with some observational study and some recommendation. But if you want to use, you have to use the smaller dose of rivaroxaban or apixaban. rivaroxaban or rivaroxaban, the smaller dose. Now, whether I will use warfarin, again, you can use it, but I showed you some data that rivaroxaban actually is associated already with arterial calcification and calciflexes and glomerular hemorrhage. So probably is not the most pleasant agent to be used.
Any questions from the audience? Okay, Dr. Adel, thank you very much for
Thank you very
your
much.
presentation. We appreciate
Thank you.
that. Thank you. Now I will call Mr. Chairman of the guest, Dr. Fawaz Mtairi, to moderate the next session. Meet the legend.